Welcome to the InTouch Health webinar series. This is Rachel, and I will be your host for this webinar. Today, we will be featuring Dr. Yulun Wang, Founder, Chairman, and Chief Innovation Officer of InTouch Health, and he will be presenting his perspective on the top telehealth trends. Yulun Wang launched his career at the intersection of healthcare and technology with the founding of Computer Motion, Inc. and the invention of ASOP, the first FDA-cleared surgical robot. Under his leadership, Computer Motion went public in 1997 and later merged with Intuitive Surgical to forge the multi-billion-dollar surgical robotics industry. In 2002, Dr. Wang founded InTouch Health, which has been recognized as one of the fastest-growing healthcare and technology companies by the like of Inc. 500 and Deloitte 500. We will begin our webinar shortly, but first a few notices. You all have been auto-muted. If not, please make sure to mute yourself. At the bottom of your audience console are multiple application widgets you can use. If you have any technical difficulty, please click on the Help widget. It has a question mark icon and covers common technical issues. You can expand the slide area by clicking on the Maximize icon on the top right of the slide area, or by dragging the bottom right corner of the slide area. During the webinar, you will be able to enter questions in the Q&A widget located on your audience console. Please note that for this webinar, questions will be answered after the event via email, so please feel free to ask your questions at any point. And now, without further ado, here's Dr. Yulun Wang.
Thank you, Rachel, and it's a real pleasure to be speaking today about the top trends in telehealth. My talk today is going to have a first few slides of framing the problem around telehealth, and then I'm going to go into 4 distinct trends and things which I think are significant, which are driving the evolution and adoption of telehealth. So to start with just a few framing slides, I think we all know that the challenge that we have in our society and around the world is building a healthcare system which can consistently provide high-quality care, do so to everybody, but also the big kicker is how do you reduce costs while doing that? And in addition, we have these trends which are undeniable with regards to the aging population, the increasing population, and then another trend which is, not talked about on the front page of newspapers as much, but critically important as well, is the advancement of medicine, which evolves with the evolution of more and more subspecializations of medicine because of the complexity of the types of treatment which people are inventing to give us longer and happier lives. So all of those trends are making our healthcare system kind of implode under its own weight. And what I believe is very, very true is that telehealth is a cornerstone to the solution that we're all seeking, which is the consistently high-quality care to everybody at a lower cost. And at a highest level, the way it works is that even though a tremendous amount of money and effort has gone into the digitization of information, the digitization of clinical data around a patient, the ability to run more and more analytics to provide the clinician the best available decision-making capabilities on how to take care of patients, if there's a limitation on how many patients that physician or specialist can take care of, then we still have a bottleneck in our healthcare delivery system, and telehealth is intended to eliminate that bottleneck by enabling that clinician to provide care to that patient anytime and anywhere he or she might be situated. So those are kind of some of the framing slides. And now if we get more specifically into telehealth applications and moving into this trends, let me first say that there's really kind of three main categories of users of telehealth today. That's kind of how it's emerging, at least from a market dynamics perspective. There are the employers who are deploying who are purchasing and using telehealth solutions to help take care of their employee patients. There are the payers who are using telehealth also to provide access of care for care for their constituents or the people whom they insure. And there are the health systems and providers who are using telehealth. And to be frank, it all hinges on the right side there with regards to the health system providers, because even the payers and employers, the payers and employers, they're using telehealth services, but all of them are being provided by providers either directly through physician relationships or through health systems. So I'm going to focus on the right one, which was the healthcare systems and providers. So my talk moving forward here is focusing on that category as opposed to telehealth for the payers or employers. And this next slide, I think is it's simple, but hopefully a bit insightful in terms of the three reasons health systems use telehealth. And if you start from the left, health systems, as they're evaluating the adoption of telehealth, the one thing they want to be thinking about is what is the most easy and most cost-effective way for patients or their consumers to access their health system. And that's one usage of telehealth, where these ideas of virtual clinics, of retail clinics, of direct-to-consumer accessing capabilities, where the telehealth can be used to provide effectively a front door into the health system. So that's kind of one category. A second category, the middle one, is to leverage expertise to improve care and lower costs. The health systems are the people or the organizations which have all the specialists who take care of patients who have, cardiac diseases, neurological diseases, require surgery, et cetera, et cetera. And this center category is where health systems should be thinking about how to use telehealth capabilities in order to leverage those unique expertises that they have across their consumer and patient base, whether it's inside their the four walls of their health system, or even extending outside of the four walls into the community in the form of long-term care settings, urgent clinics, et cetera. And then finally, the right side is using telehealth to provide a continuum of care for patients as they actually are discharged from the hospital back into the community setting. And this is particularly important, especially as reimbursements are shifting with regards to bundled payments, population health management, et cetera. So I believe, it's always hard to make complete overhauling categories, but I believe that pretty much all of these telehealth applications are justified and fit into one of these three areas. So let me go into the four top trends that are going on, which are shaping the telehealth industry as we're moving forward. The first one is the fact that the historic barriers are coming down. So I'm going to first talk about that a little bit. Then I'm going to talk about how, as InTouch Health has seen the marketplace, health systems are evolving from looking at telehealth from a service line by service line basis to thinking about adopting telehealth across their enterprise. The third thing I'm going to talk about is how data analytics which help guide the practice of medicine, are being incorporated into telehealth solutions. And then finally, I'm going to talk about how even this very hot area of artificial intelligence and machine learning is being built into telehealth solutions as well. So starting with the first one, I think, the area of telehealth started decades ago now, has been slowly being adopted over many decades and has hit an inflection point just in the last few years because of a number of reasons. But one of the reasons is because a driving reason is the need to provide high quality care to everybody and do it at a lower cost. But the barriers of reimbursement, licensure, credentialing, privileging, and legal and regulatory barriers have been challenging and have been holding back the adoption of telehealth deployment. So I guess the first trend I wanted to talk a little bit about was the fact that each of these barriers are going down. They're not gone by any stretch, but significant progress has been made in terms of bringing those barriers down. So for example, in this area of reimbursement, with the Affordable Care Act passed and even just healthcare reform, which was happening in general, perhaps even despite some of the Affordable Care Act in some cases, the shift from fee for service or fee for volume to fee for value is clearly well underway. If you look at this slide, already 85% of Medicare payments has some component of value-based reimbursement as part of it. For example, pay for quality metrics in terms of some kicker at the end of the year, or even some reduction at the end of the year based on how a health system's quality metrics are coming in. And then 30% of those payments are even more aggressive in terms of alternative payment methods like bundled payments or total risk-based payments where the health system has taken on the full risk of the patient. That trend, so it's already well along the ways with the 85% and 30% penetration as of this year, and by 2018, only 2 more years away, Medicare announced that 90% of payments will be tied to some type of quality metric or metrics, and 50% will be based on alternative payments. And as we know, where Medicare leads, Medicaid and private payers follow. And so if we start looking at reimbursement outside of the Medicare area and think about it from a private pay and Medicaid level, we have it on a state-by-state basis where today 31 states and the District of Columbia have already passed parity laws with regards to payment for telehealth interactions, and then another 7 states have similar legislation proposed. And so I don't remember the exact numbers, but if you go back a few years, that number was substantially lower. And so not only do we see a large number of states having passed parity laws, but I would suggest the slope is still very meaningful. With 7 in the pending state, you go 7 plus 31, you're already up to 38. We're getting pretty close to parity laws in all 50 states. Then if you go into this area of licensure, in 2015, the Interstate Medical Licensure Compact was passed by the Federation of State Medical Boards. The people who are strong proponents of telehealth, like myself, are believe that one of the big barrier reductions that could happen is national state licensure, but that's I don't believe that's going to happen anytime soon, and I don't think others believe that either. But this is definitely a step towards that, where now a physician who wants to practice in multiple states simultaneously can just apply for licenses at one place at the Federation of State Medical Boards, and by use of this compact can get multiple licenses in the same process that it would otherwise take to get one. And we have 18 states which have enacted this licensure compact, and there's another one pending. So again, this was just passed in 2015. We're already up at 18 plus potentially one, and so you can draw your own conclusions in terms of slope. That's certainly happening as well. Then with regards to the credentialing side, as opposed to licensure, the credentialing by proxy was passed by CMS or given approval back in 2011. So this has been around for a while, where sites which are JCO certified can actually rely on the credentialing of another site so that hub-spoke systems, et cetera, can be more easily accomplished by using the credentialing process of one hospital to credential a physician into multiple hospitals. And one more with regards to historically what's been happening is things like telehealth solutions have had the potential problems of running afoul of anti-kickback and Stark laws. And here is an example of the OIG providing basically support, if you will, for doing things like telestroke, which a telestroke hub-spoke network between hospitals could potentially run afoul of anti-kickback laws, but with the OIG issuance here, the OIG has determined that these type of networks do more benefit for society, and therefore these types of telehealth solutions will not run afoul of any kickback type of legal issues. So those are some of the things which have happened in the past few years which are bringing telehealth barriers down for adoption. And that trend is continuing, where there's just ongoing legislation and efforts which are bringing these historic barriers down. In 2015, the HR 2066 Telehealth Enactment Act was passed, and so that's just further promoting the expansion and usage of telehealth under Medicare. The 21st Century Cures Act was signed into law, where Medicare is being asked to review how telehealth is being used out there in the country, specifically with regards to things like originating site, so that they relook at some of the definitions around where Medicare does reimburse for telehealth in terms of where the originating site comes from, as in the patient, where the distant site practitioner is located, which technologies are used, and what types of services. All of these things are going to be reviewed, but because of this act, in the attempt of potentially making the inclusions larger, because they're pretty tight right now. For example, a patient for Medicare reimbursement needs to be at basically a rural or underserved area. The ECHOS Act is also another act which is in Congress, and it's actually being it's building on the success of the New Mexico program, where now they're looking to increase access for healthcare and rural coverage. And that's actually another one which the Secretary of HHS is being asked to report back to Congress to see how they can further drive the penetration of telehealth. So that was, perhaps one of the top trends, if you call that a trend, where the barriers of telehealth are coming down. The second one I'd like to talk a little bit about is how health systems, as InTouch Health is interacting with the market on a day-to-day basis, and we are, receiving the questions and comments being asked by health systems about telehealth. What is it that we're seeing in terms of the evolution of the marketplace? And what we are seeing is that, if you go back a few years until the more recent past, the way health systems were analyzing the adoption of telehealth was on a service line by service line basis. Service line being, say, neuroscience or cardiology or trauma or pediatrics. They would look to service line by service line and decide whether or not to move forward on that basis. And we see that changing to being more of an enterprise type of decision, which is done really at the kind of the senior level of the organization, where many different types of telehealth committees are being formed, which are reporting directly in a C-suite of hospitals or health systems, et cetera. So the service line example that I have here is, one that we at InTouch Health obviously know well, which is around this telestroke, and where if you look at the lower left graph, it's showing utilization of a hub and spoke system where the utilization of these hub spoke systems are going up, and the segmentation of the blue bar relative to the gray bar is showing the number of transfers. And so one of the benefits, which is I think you could pretty much say has been proven, is that maybe only 20 to 30% of patients in the outlying spoke hospitals are transferred into the hub hospital because of the telehealth network is one of the outcomes, which is saving a tremendous amount of transferring of patients, where they're able to avoid the cost of the transfer and the inconvenience of being moved into another community. In the upper right-hand corner, it's really talking about how in this particular metric, the door-to-needle time of TPA dosage has gone up dramatically from a national average of, say, 3 to 5% to in these hub-spoke networks slightly below 20%. This is a recurring theme as well. But, it very importantly as well, in the lower right-hand corner, it's talking about the monetary impact to the program, where the hub systems, because of the transfer in of the high acuity patients, where additional therapy is being applied to the patient, this actually drives a strong economic model as well. So this is really one example of where it's really driven telehealth in the health systems from a service line by service line basis, and the more forward-looking systems are starting to, apply telehealth across lots of different service lines, as indicated here by Dignity Health. But still, very often, what's happening is they're making business cases for each of these individual service lines. Now, with the transition of reimbursement happening at a more rapid pace, as I pointed out earlier in this presentation here, and the penalties as well as payments being structured more to health systems, where they not only have to view their patients within the boundaries of their four walls of their health system, but also in the post-acute manner after their discharge, and at the community at large, what's happening is that health systems are thinking about how telehealth should be deployed on an enterprise level. So here's an example of a slide actually created by Thomas Jefferson University. And the reason I have this slide up here is it's a representation of an organization who is thinking about telehealth from an enterprise perspective. So if you go around the outside circle, it goes from e-visits, on-site clinics, urgent care, virtual clinics, critical care, virtual rounds, post-discharge, and remote monitoring. All of these capabilities can be achieved through telehealth, and they really follow patients from the community into the hospital and back out again, from being well to being sick to being very sick to back well again. And so the whole point is that you can deploy telehealth in each of these different applications, if you will, and if you do, you really need to think about how they all stitch together, and you really need to think about it from an enterprise and totality perspective. Here's another one which was actually created by the Mayo Clinic. And again, it kind of goes in a circle. The patient is in the center. And if you look at the lower left third of the circle, it's in this kind of self-directed area where it's really, the Mayo Clinic is just enabling patients or consumers to reach in unmanaged, if you will, by the Mayo Clinic themselves. Then, if need be, there becomes a facilitated portion part of it, which is the top third. And then on the lower right side, this is where we generally think of healthcare in terms of the health system, where it's co-managed by the patient and the clinicians in order to provide care. And once again, there are lots of different applications listed in this diagram, and all of those applications together, if you're going to be thinking of using telehealth across them all, then you actually really need to think about how you stitch them all together from an enterprise perspective. So here's a slide that we at InTouch have created, and again, if you go back to those last two, there's a lot on them, from the Jefferson to the Mayo Clinic. And perhaps there's so much on them, it makes it hard to figure out where to start and how to categorize in appropriately sized buckets. What I've done in this slide here is, if you look at the top side of the slide, it says health system telehealth needs. And this is how we're looking at, how to categorize how health systems are evaluating the adoption of telehealth solutions into really kind of what this shows us 5 buckets. There's the high acuity bucket, which is, again, leveraging their specialists across, both inside the health system as well as outside the health system to bring the right higher level expertise where needed, necessary. There's the post-acute side, which is more following patients as they are moved out into different care settings as well as into the community, for example, in dealing with bundled payments and intersecting with patients as they're returned into long-term care, et cetera. And then on the far right side, it says RPM, and that stands for remote patient monitoring, and that's taking care of patients who are chronically ill, who need care on an ongoing periodic basis, and that's obviously, what we all know is a very high cost part of the healthcare system. And then on the far left of that upper rectangle, it says consumer directed. This is when I was talking about kind of the front door, using a virtual care to become a front door of the health system. And then above all 4 of those components, it says physician coverage gaps. What we believe to be true as we intersect with the marketplace in all the healthcare systems is all healthcare systems, the biggest to the smallest, all have coverage gaps with their physicians, both in terms of specialty as well as primary care. Sometimes it's because they just don't have the physicians. Sometimes it's because the physicians they have are already fully utilized. Sometimes it's because those physicians are utilized not only for taking care of hospitals and patients in the hospital, but also patients in their own offices and clinics, and therefore don't have excess time to support some of the health system or hospital needs. So, I personally think that this bucket of 5 on the top the consumer-directed, the high acuity, the post-acute, and the remote patient monitoring, the physician coverage gap, is a way to think about your health systems in terms of which of these do you want to fill first, which are the ones which are most important to you, and how to do it. Now, what we're doing, obviously, at InTouch Health is that lower rectangle, which has got a number of things that we have developed or are currently developed, being in order to fill those 5 top categories with regards to our cloud, which deals with the security issues, the access controls, the reliable connectivity, with regards to user interfaces for ease of use, for things like business intelligence, which I'll be talking about in a little bit here, for workflow applications, and for the ability to use a telehealth solution in order to leverage remote physicians to fill physician coverage gaps in the health systems. So this is hopefully another view of how a health system should look at an enterprise solution relative to looking at telehealth solutions from a service line by service line perspective. So now if I go into the third trend, which is integrating data analytics into telehealth, one of the things which is actually so exciting about telehealth is that by virtue of the medium by which healthcare is delivered, in other words, a clinician on one side, a patient on another side, technology in between facilitating that interaction, there is the immediate ability to capture data about that interaction seamlessly. In other words, it doesn't require someone going over to a computer terminal later, punching in a bunch of results of an interaction or writing notes. It actually just happens seamlessly to the clinician-patient interaction. And so this is where data analytics, I think, is going to become stronger in a lot of senses by adoption of telehealth and even in person. So for example, at this stage, we're still early in this journey. But for example, at InTouch, we can already tell who's using the system when, for how long, into what locations. And then if you know who the who is, you actually know which service lines are being involved, because if it's a neurologist, you know it's for a neurological consult. If it's a cardiologist, you know it's for cardiology. If it's an intensivist, you know it's for ICU, et cetera. You can determine times of day when volumes are higher or lower, so that you can make sure your clinical staffing is appropriately adjusted. You can tell where patient flow patterns go, especially as you bridge multiple hospitals. If consults are coming from a particular area and then are transferred into a larger hub organization, you can see where those are coming from. You can tell where there's more learning that needs to take place because a consult was perhaps unnecessary at one location, so now more training, which basically gives the health system knowledge that some more training resources have to be applied in that particular area. And then you can also tell the growth of your program. You can tell the robustness of the program as well. We have a number of slides in here, like the center one in this slide here, service cases and disposition. The one on the left, system uptime by location. These are more just about the technology in terms of how confident the clinicians are in using it on an ongoing basis. And then you can start getting into actual clinical outcomes. Here again, on a telestroke scenario, we'll do roughly, our system will be used in roughly 100,000 telestroke consults this year. And we can tell that 80% of them were used where the door-to-needle time was within the Joint Commission's goal of 60 minutes. We can tell actually specific organizations if they're falling out of that, the other 20%, if they're perhaps missing that Joint Commission goal. And then as we dig further, we can tell where in their workflow it might be slightly off, or what the other 80% are doing, which is generating the more efficient time frames, and we can help organizations move to perhaps the best practices in order to optimize their telestroke interactions. Similarly, for the psych consults in the ED to triage patients, we know, for example, that 100% of our customers are triaging their telepsych patients under about an 8-hour time frame, which is significantly under the national average as it exists today. So this data analytics part, as layered on top of telehealth, I would suggest is still in the early days, but is going to be extremely powerful, and perhaps will even become more powerful than analytics achieved through in-person interaction. So the final trend I'd like to speak a little bit about is this machine learning into telehealth. And I think that so we're even earlier into this phase, but I have a feeling this is going to be incredibly exciting and be disruptive in a positive way to actually healthcare delivery. So first, let me kind of point to this 4-layer cloud. If you think of the telehealth system as being created by a cloud network on top of the internet, I think we believe there's basically 4 kind of key steps. The first one is the base level needs, which you have to just enable a telehealth interaction. You just need reliable connectivity, compliance, ease of use, access control, security, et cetera. And that's actually just foundational. Without it, you can't even do telehealth because nothing's connected to whatever. The second layer is the one I was just talking about a little bit, which is this data analytics layer. And this is actually, it's early, but it's already very clear that this will be a big part of telehealth systems, which allow health systems to be able to have better insight into how their healthcare is being delivered across their system. This third layer, it has the term machine learning, data mining, and image processing in it. I'm going to talk briefly about image processing and then machine learning. And the fourth layer I'm not going to talk about today because it's kind of a catch-all, which it's a future, which is stuff yet to be invented. But I think these first 3 layers, there's real activity and real opportunity happening already today. For example, in this third layer of image processing, some of the work that we're doing here is working to add perhaps unique sensor systems that give the remote clinician additional insight on that patient, which otherwise could not have been immediately accessible if they were in person. So, for example, this is a picture of a remote clinician looking at the same patient through the left image and the right image, where on the right side it's a thermal scan of that patient, and you can immediately tell how the left foot is much hotter than the right foot, giving the clinician some information about circulation of that patient. Again, that's not immediately accessible by just looking at the patient. So that's just a quick example of image processing. But then if we get into this area which we're calling machine learning, in machine learning, it's really a form of artificial intelligence And, I come from a technology background, and I've been aware of, what's been going on in artificial intelligence for several decades. And in a general sense, in the 80s, there was a big movement to this thing called expert systems. You may remember this term, expert systems, which was you interview a bunch of experts for a long time, and you figure out algorithms based on that expert, and then you program that into a system. That was in the 80s, and that kind of went through a fad, if you will, of up and down. And it's not a fad in the sense that some of that expertise is actually still built into programs today. Then in the 90s, there was something called a neural net, and a neural net was a brand new type of computer architecture, and it's defined by this sentence here. Machine learning is a type of artificial intelligence that provides computers with the ability to learn without being explicitly programmed, and can grow and change when exposed to new data. And so this is an area where, back to my story, in the 90s, this concept was being explored. It kind of went through a whole excitement phase, but then it petered out, because at that point in time, the neural networks that were being developed were not really very capable of doing anything. And now we're on a resurgence again, and it's really, and I would suggest to you that it's very exciting, and this time it will be making some foundational changes. And it's coupled with the last segment I talked about with data analytics, because of all the big data sets that are being created in healthcare by the digitization of medicine. You can now apply machine learning capabilities to these large data sets, which then provide providers and health systems more insight into what's going on with their business as well as their patients. This is a slide which was sourced by CB Insights, and these are the number of early-stage companies that are building new businesses based on machine learning. And you can see there's a lot of them here, and these are being funded with significant dollars in Silicon Valley, in Boston, all around the country and around the world. And I believe this is going to become a very disruptive sector, which will layer on top of telehealth. And that's why I'm bringing it into this dialogue, because this machine learning AI, in many dimensions, will couple with telehealth as we move into the future. Just kind of one proof point on this machine learning, and what really got a lot of this excitement going is one of the areas of that machine learning is being applied is image processing and image recognition. And what this slide shows is that just in the last few years, it's been shown through machine learning that computers can recognize images now better than humans. You see that crossover point in 2014, where now if you put a bunch of images in front of a human and have them identify everything they see, versus you do that in front of a computer, not only can the computer do it much faster, but they can do it more accurately. And that trend line is continuing to become better and better. In fact, some people are projecting near perfection just in a couple of decades here. And image recognition, as you all know, is a big part of healthcare in all the different types of images we deal with regards to patient data. Just to bring that to a very concrete example, in the example of dermatology, wound assessment, or any time you're looking at a patient for whatever reason, if you can have the computer looking at that patient simultaneously through machine learning, it can actually inform the clinician with much better data sets than that clinician is able to remember in his or her brain. And there's major efforts in this area going on, for example, with like IBM Watson, et cetera. So in conclusion, so those are the 4 trends that I thought were worth highlighting today. The reduction of telehealth barriers, the evolution from service line to enterprise, the inclusion of data analytics into telehealth solutions, and last but not least, the inclusion of machine learning into telehealth systems. So you can think of it like this, where you got a clinician and a patient which are connected to a telehealth cloud, and because that cloud is there, it's automatically taking and sampling the data to be able to do data analytics on top of and provide that type of feedback to the health system. And then last but not least, you can actually use that data and apply it machine learning to provide better insights to the clinician, to the health population at large, and to the healthcare system. So with that, I'd like to thank you for your time and listening to me here, and then also open up for any questions.
Thanks, Yulun. We'll now begin the question-answer portion of our webinar. As a reminder, questions will be answered after the webinar via email, but please make sure to get your questions in using the Q&A widget on your console. We'd like to give a big thank you to Dr. Yulun Wang for today's presentation. For additional questions or information, please contact us at feedback@intouchhealth.com. Please visit our website to find a recording of this webinar, along with a list of upcoming webinars in our series. This concludes today's webinar. Thank you all for your time and have